Again, and first of all, I would like to thank Artur for the invitation. My first time in Krakow, and I'm really impressed. I will definitely come back. I will be very happy to discuss with you what we consider as treatment for AL amyloidosis today with the data that we have. These are my disclosures. I will not discuss about the diagnosis of the disease and the challenges in the diagnosis. I will go directly to the treatment. Let's say that we have the patient diagnosed, and we have to set the goals for treatment. And what are the goals for the treatment for patients with AL amyloidosis? We have to remember that these are not patients with myeloma. These are patients with a plasma cell dyscrasia, could be also a myeloma, the cause of the disease, but it's much more complicated. This is a really complicated plasma cell dyscrasia. So what we have is two levels of response. One is the hematologic response, then the one that we fully understand. You need to eliminate the light chains in order to achieve organ response, in order to improve overall survival. However, there are some open topics there. One is, what is the depth of response that you need in AL amyloidosis? And also, how fast you need to go to this depth of response. We have to remember that the criteria for response in AL amyloidosis are not the same as in myeloma. They are mostly based on the free light chains. There are many issues with the measurement of the free light chains, and of course, there are many challenges. But as you can see, the best responses are those associated with very low levels of light chains, because these very low levels of light chains are associated with a really improved survival in these patients. And if you achieve this deep level of hematologic response with very low levels of absolute light chains, then you can expect to see an involved organ response. So to see some degree of improvement in cardiac function or in renal function. However, one has to remember that quite often these organ responses are delayed. It may take years to see a meaningful clinical response. Also that, although you may have a very deep hematologic response, it may be too late for the organ. The organ may be already so much destroyed that the organ function cannot be improved and be non-reversible. So, how deep do we need to go to get the best organ responses? As you can see, if you achieve, let's say, a partial hematologic response, the organ responses are not very high, are actually low. The deeper you go in terms of hematologic responses, the higher the probability of an organ response. So complete hematologic response means that about 50% of the patients will achieve an organ response, which is okay. MRD negativity, as assessed by next-generation flow and next-generation sequencing, can be associated with a substantial improvement in the rates of organ responses. Why? Because probably there is a residual production of toxic light chains that we do not detect with the traditional methods that we have to measure free light chains. In addition, MRD negativity is associated with a very substantial reduction in the probability of hematologic relapse. And as you can see, these curves are very different than in myeloma. MRD negativity is associated with a really substantial reduction in the risk of relapse. Why? Probably because the clone is very, very small. And even if there is some residual that we don't detect, it takes a lot of time to make a hematologic relapse. So I would like to have this as the goal of treatment for all my patients with AL amyloidosis. Now, the question is, how fast do we need to go there? I would say the fastest possible. Why? You can see here an analysis from our department. You can see the difference in the overall survival if you achieve a very good hematologic response after 1 month or after 3 months. You can see that, it makes a difference. However, what is very important is, If you compare in a landmark analysis patients who achieved a very good hematologic response at 1 month versus those who achieved the hematologic response, the very good hematologic response at 3 months, there is a significant difference in the overall survival. It's the orange and the green lines. Just because there was a delay of 2 months in achieving a very good hematologic response. 2 months of delay, substantial reduction in the overall survival. Also, only 25% of the patients that did not achieve a very good partial response by 1 month, they achieved with the same therapy by 3 months. So it looks like this is a disease where you either treat the patient within 1 month you make a decision to continue or change the therapy, or you may lose patients and you may lose time. So, in summary, treatment goals: deep hematologic response, ideally up to undetectable minimal residual disease. Rapid hematologic response, I would say, within 1 month. Cardiac amyloidosis, even faster. And because these are patients who have severe organ involvement, cardiac dysfunction, renal dysfunction, peripheral nerve dysfunction, you have to use a treatment that has low toxicity. Now we get into difficult fields. What are the available therapies today? These are, let's say, the contemporary regimens that we have, based on bortezomib. Bortezomib with cyclophosphamide and dexamethasone, this is the classical regimen over the past years. Maybe with melphalan, bortezomib with melphalan and dexamethasone, there is a randomized study, phase 2 study. VRD, which is very popular in myeloma, it is associated with good responses in AL amyloidosis, but substantial toxicity. So in this study, we used weekly bortezomib and 5 milligrams of lenalidomide, and 57% of the patients required hospitalization. So it's not easy to use what we have in myeloma, also in amyloidosis. And of course, you know the results from the Andromeda showing that the addition of daratumumab, subcutaneous daratumumab to VCD substantially improves complete hematologic responses and organ responses, almost doubles complete responses and organ responses, but again, we are far from ideal. And of course, we have to remember that these studies excluded patients with stage 3B amyloidosis, those with severe cardiac involvement. So there are many open issues still there with the available therapies. You know the results from the Andromeda study. It was one of the biggest randomized prospective studies in AL amyloidosis, comparing VCD to DARA-VCD, doubling on complete hematologic response rates. They reached, with the additional follow-up, to 60% of the intention to treat population, and also they were achieved within 2 months. But still 40% of the patients failed to achieve a complete hematologic response, which we said it's at least the ideal, CR and MRD negativity. VGPR is good, but probably not so good. And also, it takes still some time. It takes about 2 months to reach to CR. But most of the patients achieved VGPR within 1 month. So a very good regimen, not the perfect regimen. We still need some improvement. Also, we have to remember that in this analysis, you can see what happens if the patients achieve VGPR by 1 month or by 3 months. You see the substantial improvement in MOD-PFS. However, what is very important, the patients, among the patients who did not achieve this goal at 1 month, there were just 25 more patients after 2 months. So with DARA-VCD, if you fail to achieve a VGPR by 1 month, by continuing the same therapy, there is not a much probability that you will really improve your depth of response. So perhaps even with DARA-VCD, one has to be aware that maybe, at least for some patients, needs to make early treatment modifications. We know that cytogenetics in patients with amyloidosis are not so often the typical high risks that we see in myeloma. About 40 to 50% they have T1114, which is considered, let's say, neutral in myeloma patients. But here, as you can see, this is not so good. So T1114 in patients with amyloidosis is associated with an inferior response to bortezomib, which is one of the main drugs. So this is a huge issue. Fortunately, the addition of daratumumab seems to be able to overcome this effect of T1114, and I think that is why we need definitely to have daratumumab, at least in patients who harbor T1114 as part of their primary therapy. The good thing is that we also have a drug that targets this translocation, the biology under this translocation. And as you can see, patients who have T1114, they respond very, very nicely to venetoclax, even to single-agent venetoclax. However, we do not have prospective studies. We only have retrospective data. Anyway, because of the good results, we use this regimen, this drug, in our patients with T1114 if they fail daratumumab-based therapy. Of course, there are many issues there, like, should we just start these patients with daratumumab or venetoclax, or just venetoclax alone from the first line treatment, or should we combine venetoclax, and what is the best combinations? We should see that in future trials. As I told you, with Andromeda, we see about 50% of organ response rates, but still 50% of the patients fail to achieve an organ response. So we need something more to improve the organ response rates in these patients. We are far from ideal when we say that 50% of our patients will respond and 50% will not. And this is just a summary of the current unmet needs of the upfront therapies that we use today. Toxicity, further improvement of hematologic CR rates and organ response rates, and of course, the big question, how are we going to treat patients with stage 3B amyloidosis who have a median survival of 4 to 6 months? These were not included in Andromeda. And how are we going to reduce early mortality? Because this is one of the biggest issues, early mortality. And as you can see here, the early mortality between DARA VCD and VCD is identical in Andromeda. So early mortality does not change with just adding an additional drug to a current backbone therapy. We need probably to reduce toxicity, and second, to do something for the cardiac function, because these are patients with severe cardiac dysfunction. So is DARA VCD the perfect regimen? Here are the toxicities of DARA VCD and VCD, and these are the toxicities that were observed when VCD stopped and patients per protocol continued with DARA monotherapy. As you can see, there is a substantial difference in the toxicities. Why? Because most of the toxicities are related to bortezomib and dexamethasone. Some of the toxicities are more often with daratumumab, like infections, but generally, I would say that most of the toxicities are VCD related. So, can we further reduce this toxicity by further adapting the dose, giving lower doses, omitting bortezomib, or omitting steroids, further reducing the dose of steroids? We tried to address that in the EMN 22 study, which is a prospective study in which included only patients with stage 3B disease who were treated with daratumumab as a monotherapy. The primary endpoint in this study was overall survival at 6 months. You cannot say that this is a very optimistic endpoint to have overall survival at 6 months, but because these patients have a 6-month overall survival rate of about 40%, we consider that this could be an early time point to address the efficacy of this drug. And as you can see, we did see a significant improvement in the overall survival, but what is very important is to see the two phases of this curve. If you achieve a very deep hematologic response and the patient survives 9 to 12 months, things change. And this is really what we see in this study, which has now completed accrual. And of course, there are ongoing studies further examining combinations with CD38 monoclonal antibodies. I think this is very interesting because they start with isatuximab, then they add bortezomib if everything is okay, then they increase the dose of dexamethasone, then they increase the dose of bortezomib, you know, a step-up dosing approach. But the big news are the bispecific antibodies, and I think this is one of the biggest improvements that we will see in the treatment of myeloma. Fortunately, we have 3 approved, and there are more coming. And one question was whether we could further, you know, combine bispecific antibodies. Oh, here are these bispecific antibodies and other drugs. So, bispecific antibodies for AL amyloidosis. That would be fantastic news, and there is some small experience which is really astonishing. But we need more data because these few anecdotal cases, you know, are very selected cases. I'm not sure if we can go to primary therapy with these antibodies, but certainly this could offer a very effective fixed duration, probably not for until progression. We don't need that in amyloidosis. Fixed duration immunotherapy. Monotherapy or combination, this is something what we should see. The issue of toxicity, of course, is important. The experience that we have today is that CRS is not a problem. I think we can manage CRS very, very effectively and preemptively. I would say that neurotoxicity and infections is probably the biggest problem that we will have with these drugs, and perhaps in time we may see a few specific toxicities related to AL amyloidosis with these bispecific antibodies. So, in summary, the treatment for AL amyloidosis today should be risk-adapted, where risk is defined by the cardiac stage. And as you can see, for most patients, dara-VCD is the primary option. For some patients, autologous transplantation could be a good consolidation strategy. But for stage 3B patients and some patients with stage 3A, I would say give lower doses with daratumumab, but lower doses of the other drugs. The clone is very important because some of these patients have big clones, and these clones need to be eliminated. They may require longer therapy, meaning further consolidation and maintenance. And also, 50% have T1114. And I think in clinical practice today, not giving daratumumab in first-line therapy for patients with T1114 is not very good because the CR rate in patients with T1114 who receive just VCD is 10%. It's very, very low. And of course, if available, one can consider venetoclax as second-line therapy. But these are very sick patients most of the time, and they may need to adapt some therapies and avoid some therapies because of pre-existing neuropathy in about 25% of the patients, diarrhea, heavy proteinuria, very high risk of thrombosis, very low levels of albumin. You may need to omit bortezomib because of involvement of the GI tract, et cetera, et cetera. So for second-line therapy, there is a mess, actually, because in AL amyloidosis, we do not have clear criteria of what is a relapse. What is hematologic relapse, organ relapse, not ideal response, et cetera, et cetera. So things are very complicated. What we try to do is not exactly following this criteria this criteria. Our strategy is to treat patients who have not achieved a very good partial response, irrespectively of whether it's a first-line therapy or they increase their light chains. One has to be aware that even small amounts of these light chains could be very, very toxic, especially for the heart. So waiting to see a significant increase in the light chains, I don't think is an option for the majority of patients. There are always exceptions. What can you do in relapsing patients. If they have not received daratumumab, you can give daratumumab or isatuximab. If they have received daratumumab, things are more complicated. If they have T1114, of course, you can give venetoclax if available. And at the second line, you may start considering lenalidomide or preferably pomalidomide, because these drugs are not very well tolerated or very active in these patients. This is just a summary. And I will end this presentation by saying 2 words, 2 slides for the amyloid targeting monoclonal antibodies that are in development. We have 2 such monoclonal antibodies who are in phase 3 clinical trials. The one that has no name yet, or I don't remember the name, to be honest, from Kaelum, which is now with AstraZeneca, I think, or Alexion and AstraZeneca. I think they are together. I miss this company stuff. Anyway, this study is addressing the addition of this monoclonal antibody to standard therapy in patients with stage 3A and 3B disease, those with more severe cardiac disease. The first one on stage 3A has completed accrual, so we'll just need to wait for the results. And the second study in stage 3B disease is still accruing patients. And we have birtamimab, which had 2 failed studies, Pronto and Vital study. However, in a post-hoc analysis, there was a benefit, a significant benefit for patients with revised Mayo stage 4 disease that did not include stage 3B disease. So for a very, unique population that was sick, but not too sick. And this post-hoc analysis was done after stopping the trial, led to a new study that is ongoing and is accruing patients, the AFFIRM study, in which, again, this drug, birtamimab, is added to standard therapy to dara-VCD. And with that, I would like to thank you for your attention, and also, of course, thank for the invitation, and my department for the whole support. Thank you very much.
Because of time limits, we have time only for 2 short questions.
Thank you for a wonderful presentation. I'm interested in cardiac amyloidosis, ATTR variety. Do you have experience with tafamidis, and it's possible to reverse chronic heart failure with this drug?
Yes, we do have we do see a lot of patients with TTR amyloidosis. We do have extensive experience with tafamidis. Tafamidis is an extremely well-tolerated drug, but you have to wait a lot to see, efficacy. So in our experience, you need about 1 year, 1.5 years to see some form of stabilization of the disease. I can't say that we really see significant improvement in any of the parameters of cardiac function or a 6-minute walk test, but it is a drug that can really slow down the process of ATTR. Also, we have a new drug. We have acoramidis, which showed a few days ago very positive results. Again, it's a stabilizer, very well tolerated. It's a pill. But we will have to wait for this drug. And there are ongoing trials with siRNAs that target the production of the TTR from the liver, also in patients with non-mutated, with wild-type TTR amyloidosis that are ongoing.
Okay, Stathos, nice presentation as always.
Thank you.
From you, just question. You mentioned that the challenge for us is stage 3B patients. It's really a challenge. Do you have any experience with heart transplantation?
Yes. Unfortunately, the experience is is small, and the reason is, there are 2 reasons. One is that in Greece, we do have a general problem with heart transplantations. We don't have too many donors. And the second is that the cardiologists are afraid to go through heart transplantation in patients with AL amyloidosis. In our small experience, the results were very good, very good. And the problem that we have with one patient was CMV reactivation and not cardiac problems. And because of the CMV reactivation and the complications from the CNS, the patient is alive, for example, for several years now, but not in very good mental condition. So it's challenging, but I think that in selected patients, especially those who are MRD negative and they, you know, see a deterioration of their heart function, they should be transplanted, if there is available, of course.
Thanks. Our approach is slightly different. We started this program like 2 years ago, and because we lost a lot of patients, you know, 3B, hematologic remission, and we lost patients because the sudden death, it's clear.
Yes.
So we started with program, DARA approach, 2 cycles. If they are really sensitive, close to hematologic remission, indicated heart transplantation. Very difficult upfront to persuade the cardiologists, but they finally agree. So we have close to 10, 12 patients now. Quite good experience.
That is a fantastic approach. You know, the logistics of the transplant, of course, are very complicated, but it's fantastic.
Was there any
approach.
interaction with immune suppressive treatments and after?
You know, this another challenge is because these patients are
And doesn't it?
life on some immunosuppression, so we need longer follow-up, you know, what's happened.
But
we are confident that it's safe because it's not safe.
But there are data now from registries showing that patients with amyloidosis who had heart transplants, they have almost a similar survival with heart transplanted patients for other indications. So it's not so.
We have one patient with heart transplant. This was 45 lady, and actually the consideration was mainly cardiologists, because most of the other patients did not qualify because of cardiology reason, particularly resistance, pulmonary resistance, the problem. And this patient was, after DARA treatment, was heart transplanted, and then was transplanted with peripheral blood stem cells, and she is now 4 years in complete remission, so doing fine.
Does anybody else in the audience can contribute to this discussion? If not, so I think we have to proceed. No.
Last question. We have in Poland from a couple of weeks a program for amyloidosis. There are VCT according to Andromeda, but in the past year before it was only VCT used. I would like to ask you, when you have patients, you can imagine 60 years old gentleman after DARA VCD or after VCD 6 cycles in PR, you recommend such guy autologous transplantation?
Yes, if the patient can tolerate transplant and has not achieved the CR with DARA VCD, I would consider some form of further consolidation or change in therapy. PR is not an option for patients with amyloidosis.